So, you mentioned the dogma before, never touch the eustachian tube, you can only make it worse. That's what I was told by my mentors, Jan Hans and Henning Wilbur, in Germany. And so I was really worried, and I just want to give you a very short introduction how we came across with the idea of balloon dilation, tuboplasty. We thought, is it feasible? Why does it make sense to stick a balloon into the eustachian tube? Is it safe? I mean, there is the internal carotid artery. We know by papers by Proctor there are about 8% distances between the eustachian tube and the internal carotid artery. And is it efficient? I mean, we've seen the evolution of eustachian tube surgery, we've seen TAMS, we've seen the risk of eustachian tube surgery, so would it make sense at all? So I was talking to my junior doctors in my department, and our cardiologist left a PTCA catheter in the cadaver lab, and we were doing sinus surgery. So I tried to train him about endoscopic sinus surgery, and eventually we came across with the idea, and this was the first photo actually done. Here, the first cadaver where we did the dissection, and we actually took their pressure syringe, and then we put the balloon into the eustachian tube. It slipped in very easily, and so we had a maxillary sinus suction, as you can see on the left-hand side, and it worked at the first attempt. So then we were worried, and I was talking to my friend who said Nikotos, and I asked Nico, what do you think about the idea to stick a balloon into the eustachian tube? And he said, well, Holger, you have to do a lot of prayers before. There will be a lot of blood that will come out of the eustachian tube, and I think you will create disaster. And then I was talking to another friend from Ipswich, and he said, well, it's not a good idea. Why do you want to ruin your reputation? You have done so much research and have published so much in science. I think you're going to ruin your reputation if you do that. So that was really reassuring. And then we started with the first cadaver, and I put contrast dye into the balloon, and I was really worried, can we rupture the internal carotid artery? That was my major concern, because at that stage, we know that all the regulation is based on the cartilaginous portion of the eustachian tube. So if you tackle the eustachian tube, it doesn't make sense to try the bony portion. That has been shown by Sini, the papers about the Italian group, the house group, that published even the middle fossa to eustachian tube decompression surgery. They were not very successful by doing that. So this is the first 3D reconstruction with a balloon filled with contrast. And you see the proximity of the internal carotid artery. And looking at power calculations, you're not able to rupture the internal carotid artery. So that was the first studies that we did on temporal bone cadavers. You can see the L cells that are very close to the internal carotid artery. And you can see that the proximity towards the internal carotid artery of the eustachian tube becomes closer as we approach the middle ear. So this is the mesh temporal bone here, again giving you an idea about the proximity of the internal carotid artery and the eustachian tube. Then we did something where we tried to look at the mechanisms. That were our very early attempts on human cadavers. And you could see, when we did the balloon, you could see tears in the cartilage of the eustachian tube and ruptures of the surface. However, these were post-mortem investigations, and so I think initially we assumed that we create cracks in the elastic cartilage of the eustachian tube, but I don't think that these findings were really true. I think that Dennis' mechanism of resurfacing the mucosal layers and getting rid of a deadlock situation is a much better explanation. So, but initially we thought, because if you pioneer things, you do your own mistakes. And I think these findings are postmodern findings that are not really valid. So that was the first eustachian tube endoscope that we developed with the company of Spiegel and Tice. And you could see that we had taken these endoscopes from endoscopy of the salivary glands. However, this endoscope was really very immature and the results were really bad. But the only advantages with that endoscope were able to look inside the eustachian tube. Then, after a lot of breakdowns of the first device, we came up with the insertion device that was specifically made for the eustachian tube, and we could use that for an ipsilateral or contralateral approach that was really helpful. Technique is pretty straightforward. You want to avoid the bony part, you want to go to the isthmus region, and you want to have forth on the deadlock situation of an obstructed eustachian tube with balloon. The size of the balloon and the length of balloon dilation is still not investigated to a large extent. And I think there's a lot of work that we can still do to improve the technique. Personally, I took the pressure from angioplasty because there is a lot of research that has been done on the long term of the dilation process. What I found preferable is the contralateral approach using a 70-degree Hopkins optic, and that gives you the best visualization. If you want to recanalize the eustachian tube, or if you do that in very difficult pediatric cases, I prefer the pharyngeal approach. It gives you the symmetry of both eustachian tubes on the ipsilateral and contralateral side, and it helps you not to lose orientation because it can be really tricky in children. This is, maybe you can start the video, please. This is the thing that we do right now. So we do balloon dilation generally on an outpatient process. So we do the endoscopy of the inferior portion of the eustachian tube. You can see the cobblestone pattern. This is very typical for extraesophageal reflux. And then you punctured on the contralateral side the office of the eustachian tube. Always look at vascular malformations, they may be a problem, and then you insert the balloon pretty straightforward. What you can see once you've inserted the balloon, you can see the contractions of the soft palate. This is giving you an idea that you're in the right position and that you don't have any problems. So once the balloon is inserted, you can see the contractions, and I think you can observe that very often in those patients. Make sure that the balloon didn't tilt and that it's in the right position. Always release the pressure when you withdraw the balloon. That's a very important finding. So this is Dennis' work, and I think it's very convincing. And again, I would like to show that because I think that's probably the best explanation we have so far. That you crush down the infected subepithelial connective tissue, that you shear off part of the biofilm, and that you're able to resolve a deadlock situation. So after that, we were really excited. So I went to the local butchery to get some sheep heads, and we looked at the pressure changes within the lineage. So we put a pressure probe in the middle ear, and it took me about 2 hours to find the opening of the eustachian tube in the back of the sheep. It's just a very small valve. You can see that here. So it was not easy to be identified. And you can see the increase of pressure when you advance the balloon and when you inflate the balloon. And if you do remove the balloon in an inflated stage, you create a lot of negative pressure. So you always have to release pressure before you do that. So far, I just wanted to show you in our first case series of about 6,200 patients, we didn't see many side effects. We had cases that we will discuss in a later symposium of hearing loss. We didn't see any head-to eustachian tubes. We had about 300 cases of revision and six emphysemas. What we've seen so far is, if you have patients with liver problems, like ambient pressure problems, you can resolve them to a huge extent. But if you have like failed tympanoplasties, a lot of extruded middle ear prosthesis, or really end stage of middle ear disease, then it's much more difficult to regress that with balloon. So there is a window of opportunity, which is probably in childhood, where you're able to revert it and where you're able to use balloon dilation uroplasty. So again, I would like to thank you, Dennis, for organizing that. And please go ahead.